Dear Pure Urology viewers, good evening, one and all. Today, our topic is a little more interesting, not on one surgical technique, HoLEP versus ThuFLEP versus bipolar enucleation. As you all know, bipolar TURP is gold standard, but last 20 years, HoLEP is continuously striving to come closer to the closer to the TURP. But the problem is TURP is a cost-effective procedure. And HoLEP, because 100 watts or 60 watts is required, a lot of people in private practice were hesitant to buy it and do it. And the second thing is, any enucleation causes some amount of incontinence in the initial period, so everybody is worried about that. Now, during this process, what happened? Bipolar enucleation has come. Bipolar enucleation, you need not buy anything except one loop, and that loop will do the surgery. But this is a technically demanding, and lot people could not do it because of its technical difficulty. And again, ThuFLEP has come, which is cost effective and slightly closer to HoLEP, but not matching HoLEP. These are the gross points. But one person doing all the three surgeries are rare. Some says that I do HoLEP, nothing like it. Some say bipolar enucleation, I am master in it. But now few people like me say that ThuFLEP is also okay. So which is okay, which is not okay? The youngsters are confused what type of laser I should buy, 30 watts, 60 watts. They also wanted to do in large glands. It is actually picking up in last 5 years. So Dr. Ajay Bhandarkar sir, out of his academic interest and his own setup, he is able to do all the three procedures because probably he might have understood the basic anatomy and technique very well. With that, I will introduce sir because he is already on the PowerPoint presentation mode. Dr. Ajay Bhandarkar sir is doing second time in Pure. So for the juniors, he is consultant urologist at Sujay Urological Hospital, Vadodara. Urology training in MPUH and KMC Manipal, two very renowned academic institutions. Acquired Holmium laser in 2002, way back 2002 means when we have not joined even MCH, and individually done more than 3,000 HoLEPs. He is more known for actually prostate surgery. I think so. He also does bipolar enucleation of prostate and promoter of anatomical endoscopic enucleation of prostate. That is a word AEEP. Quite a long time it is there in the literature. He has published his techniques in Video Urology Journal also. He is Executive Council member of USI and has served Urological Society West Zone in various capacities, including Honorary Secretary between 2018 and 2020. So with this introduction, I thank once again Dr. Ajay Bhandarkar sir for accepting this invitation. My only request is take time, sir. There is no time limit. Even if it is 1 hour, I don't have any problem. But let it be a good video, which will be there, YouTube link forever. Forever means as long as YouTube is there. So I request you to focus on the basic points how these three works out. Thank you, sir. Over to you.
Hi, Chandra Mohan. Good evening and good evening all the listeners. Am I audible? Let me first check.
Yes, sir. Yes, sir.
Yeah, I'm sorry about some technical glitch because my laptop was new. I shifted my presentation on my desktop and I unfortunately opened it in the PDF format. But now I'm ready with the presentation. Thank you once again, Chandra Mohan, for giving me a time to talk to the elite listeners of Pure Urology website and the Facebook group. Like you said earlier in my introduction, yes, I acquired my Holmium machine way back in 2002, and now nearly more than 20 years, I have been doing a laser enucleation of the prostate. I have been witnessing the change in the, attitude or, I have seen all this because I have done a MCH from Manipal where a lot of prostate and TURPs were done as a residency days. So TURP, we had done plenty in my initial part of practice. Even today also I do a TURP. But you have asked me to talk about my experience on HoLEP and bipolar enucleation and thulium fiber laser enucleation. To be very honest, thulium fiber laser enucleation, I have done very few, but thulium laser enucleation, that is ThuFLEP, pure ThuFLEP, thulium YAG laser, I have used for 1 or 2 years in between. So actually, I would like I would love to share what actually my views are as far as the prostate enucleation is concerned. As I was talking about the evolution, there is a beautiful slide published in Andrology, a journal, which talks about the evolution of the prostate surgery itself. We all know that before 70s, the TURP came in early 30s, 40s, but the real, evolution came when the rod length system came, and the 70s and 80s were the decades where TURP was really very common and overtaking the open surgery. Now, open prostate surgery was again a enucleation. So the enucleation of the prostatic adenoma was the right treatment for that obstructive BPH for years together. But because we as a urologist adopted endoscopic surgery, we started resecting that adenoma, and TURP became a gold standard over a period of several decades. I would say 4 or 5 decades. So it was the 70s and 80s. Chandramohan, are you aware that there was an article published in 1991 when I was doing my MCH, and I was reading that in year 1986-87, reimbursement claims in the American insurance companies went to $2.2 billion. This information is there in a published journal. So the insurance companies in USA told the scientists and FDA that please try to find an alternative to TURP, whether it is a medical management or a minimally invasive surgery or something else. And that is how all these molecules were developed, and the number of TURPs and the reimbursement for the TURP should come down. And that was the basis of thinking that what do urologists will do. At that time, that in 1993 Journal of Urology editorial, and somebody wrote that urologists will always see the BPH patients as an outdoor patient, and whatever minimally invasive surgery, any renovation, evolution, and new procedures will come, urologists will adopt to that. And that is how we started evolving. But first transurethral enucleation of the prostate was done in 1983 by a Japanese guy. He used to use a spatula and cut the mucosa between the adenoma and the prostate capsule and use that special spatula. And he published his technique in some Japanese journal only. So the real credits of transurethral enucleation goes to that Japanese guy, Hiraoka. Okay. From that 83, it was published in Japanese journal, but never in European or American journals. People forgot about transurethral enucleation. People were busy doing transurethral resection of the prostate. I think when I was a resident in 1992, that ND-YAG laser, so that came, and that came with a side firing fiber. So the laser ablation, the word ablation came into the picture. So we started ablating the prostate, and thinking that when I was a resident, guy from the USA came and gave a presentation in our department saying that our TURPs are going to vanish and this laser procedures is going to take over, and ablation is so easy. There is no learning curve, and you just move around the fiber and the prostate gets ablated. And this is how the ND-YAG laser came into the picture, early 90s. But then we all started realizing the limitation of the ND-YAG laser ablation because it was never a complete procedure. So that started a vaporizing or ablation of the prostate. But 97, 98, it was the Peter Gilling and the group from the New Zealand. They tried holmium YAG laser in the prostate, and they also, because ND-YAG ablation was done, HoLEP was done. HoLEP, that is holmium laser ablation of the prostate. Again, the same limitation they found. The larger prostates, they were not able to do a justice. So they started doing like a resection, that is holmium laser resection of the prostate. So HoLEP was done. Again, it was a very time-consuming procedure, and somehow they found that there is a way to remove the adenoma going between the adenoma and the capsule, and the enucleation of the prostate technique was invented. The first publication by Fronderfer and Peter Gilling was done in 1996 of 18 patients, and they found that the enucleation of the adenoma, and they found a way to take out that adenoma by a morcellation. So the holmium laser enucleation of the prostate started from 1998 when they published a little larger experience, and then people started adopting this. And thanks to the media group, I got a chance to talk about the newer modalities in the prostate surgeries. And I was to speak about the holmium laser enucleation of the prostate without even seeing the holmium laser machine. I was talking about the recent advances in the prostate surgery. And that is how my interest started in holmium laser. And when the chance came, I wanted to adopt a laser machine that 100 at that time, I think 160-watt laser was there, and the highest watt was 80-watt laser available. And that was coherent laser in those days. So the coherent 80-watt laser was bought for the first time in the hospital. Now, once we started enucleating with the holmium laser, I think the bipolar also was invented in early 200, I think 2000s. And bipolar technology became popular. I think it was the Peter Gilling again, his group. They did a bipolar needle enucleation of the prostate and published this in a Gold journal in 2006. And that also attracted me towards one more energy to remove the adenoma from the prostate, because Peter Gilling already adopted that. And he said that the efficiency of that bipolar enucleation is as good as holmium laser, but there are technical and practical problems in doing a bipolar enucleation. That is the conclusion of Peter Gilling group paper published in Gold Urology journal in 2006. It was Liu who started doing a bipolar resection and enucleation with the beak of the resectoscope. And he did 1,000 cases before he published his first paper in 2010 of a bipolar enucleation. So by that time, there were several players from Europe and China who started doing a bipolar enucleation with the button and the loop. But again, Hirasawa in 2012 from the Japan, he invented a spatula, a special spatula with the loop, so that you can cut with the loop and the spatula will help you in the blunt enucleation of the adenoma. So this is how the BPCE is come into picture. And I was first to witness the Liu in 2012 when the Hyderabad conducted a workshop. And then again, this bipolar loop, this spatula Hirasawa loop, I tried to do bipolar enucleation with that. As you rightly said, it is technically demanding. I was being HoLEP for 12, 13 years those years, but I found it very difficult. Even the needle electrode recommended by Peter Gilling group, they never published any other paper after 2006, because the needle electrode was not good enough to do a good enucleation, hemostasis, and air bubble in the bipolar technology was most bothersome. Yeah. So then I found that the button electrode, that Olympus set had a button electrode. So that button electrode was good enough to do the job of a mechanical enucleation, as well as I will show you in the videos. So this is how the evolution of the laser enucleation or bipolar enucleation or other green light enucleation. Then people started using diode laser for the enucleation, green light laser for the enucleations. All sorts of energy have come into the picture. 2016 or 8, European Association of Urology, EAU guidelines, Herman first time introduced the term anatomical endoscopic enucleation of the prostate. So that is why in late last decade, we started thinking that it is not the holmium laser which does the trick, it is the enucleation technique which does the trick, whether it is a thulium YAG laser or a holmium YAG laser or a bipolar energy, you can do a good enucleation of the adenoma. So the term coined was anatomical endoscopic enucleation of the prostate. So AEEP came into the picture in the last few years of the last decade. And things have now progressed to en-bloc techniques. We can remove all the 3 lobes at the same time, or a 2-lobe technique or a 3-lobe techniques. So I'll be showing you, as you said, I am going to show you unedited videos, the direct videos.
Sorry to interrupt, last 3 years,
yes,
last 5 years, any paper has come on bipolar enucleation, sir?
Yes, there are. I'll show you. I have some theory slides also. There are analysis also about the bipolar enucleation also. So I'll show you I have some slides. If there is time, no time limit, I'm going to show you unedited videos. So it will be, this session will be like a semi-live session where you will see right from the scope insertion to the morcellation without any changes made in that original video.
Great.
So the concept we all know that, when the medical management or a watchful waiting fails in the LUTs due to BPH, we have to, recommend either minimally invasive surgery or an invasive surgery for the prostate. I am not going to talk about minimally invasive surgery today, but the invasive surgery depends on three, methods: the resection, enucleation, and vaporization, as I said earlier. But the goal of the treatment is, at the end of any treatment, we want to leave behind a wide open prostatic fossa, and it should be with the minimum morbidity. So this is how the question will come, that why not TURP? Because my TURPs are good. Everybody does a good TURP once he's a good trained endoscopist. So we have, despite doing a good TURP, we have the blood loss. There is a significant difference between the good laser enucleation and a TURP. So blood loss has always been a concern for most of the urologists, especially in a larger gland, especially in the patients who have this anticoagulants and antiplatelet agents being given to them. Continence, again, we should be doing the procedure which should not compromise the continence of the urine. And post-operative recovery should be as fast as possible. And this is a Western concept that they want to send home patients same day or a next day. In our country, we do not want them to go same day, or 1 or 2 or 3 days hospitalization doesn't cost us too much. But the recovery should be uneventful. That is what the goal of the treatment is. And at the same time, the treatment, whatever we do invasive, it should last lifelong, as on today, but it should last long, more than 10 years, 20 years. There will be some published data. You will see that there will be some nodules which are recurring, maybe 5 or 10% chance, but anything which lasts more than 10, 15, 20 years is a long-term efficacy. And this is how the goal of the treatments for the BPH surgery is defined. I'm going to share you this video of a very interesting patient I did. And I'm just starting with the, area around the verumontanum, and this is one I do routinely, and this is the left side of the apex of the prostate, which is being separated. Now you see the property of, I will come to that point theoretically later in my presentation, but here you can see the holmium YAG laser is a pulse laser. So it is not a continuous wave laser. So it produces burst, that is in pulses, the energy is in the pulses. So ultimately it is a shock wave or a tissue burst technique. So this is a non-contact technique. Like you have to be little 1 millimeter away from the prostatic mucosa. So this is how it gives the best result. And this particular patient had a creatinine of 15, and he came to me with bilateral nephrostomy and high creatinine. So I did a bilateral double J stenting, and then that is why, if you have noticed, you can see a stent on both ureteric orifice. And the prostate size was around 65, 70 grams. And a two-lobe technique I am doing because I just wanted to do it as fast as possible. And this video, you can see it is about 27 or 28 minutes. So this is a unedited 27 minutes procedure I have recorded, and you can see this in the first step. I'll be enucleating the left adenoma. The key in this particular technique is that you have to lift up the adenoma with the beak of the resectoscope, define the plane, and then you just, I'm not touching, if you can notice in the videos, I'm not touching the tissue, just 1 millimeter away from the tissue, and this energy will take care of a coagulation of the vessels and then dissection of the planes. So according to Peter Gilling, the pulse wave energy, that is holmium YAG laser, is the only laser which gives you a most anatomical enucleation. So you need to remain into the correct plane always. Now here again you can see this, there is a, if you can see my marker here, I don't know, but there will be a few nodules.
We are able to see nicely.
Right. Okay. So there will be few nodules which are densely attached to the capsule, and we may have to cut through the tissue and the adenoma. But most of the time, the plane is between the adenoma and the capsule, and these are fibrous strands. So you don't need a very, very powerful energy to do a good enucleation. You just need a good technique to, it's like an open surgery. The assistant has to hold the opposite end of the tissue and you have to cut in between at a proper plane. So maintaining a proper plane in a laser enucleation is a must. So what I am doing in this particular patient is that I am defining my plane between the adenoma and the capsule on the left side in the apical region, and I have simultaneously taken an incision from the bladder neck to the apex. So I am completing the left-sided lobe enucleation at one go. And this is absolutely unedited video. I may have to fast forward certain things to save much time. But now see this, I am going at 12 o'clock here. So essentially the adenoma is divided into two lobes. Initially, I enucleated on the left side between 6 and 4 o'clock, and I have started at the top at 12 o'clock. So this is how I am going to define the anterior capsule on the left side. So left prostatic adenoma is being separated here. I'll just see this now. These are all repetitive movement, and you will see the main vasculature coming. See, one of the best part of the enucleation, advantage of enucleation is that you are directly going to the capsule and coagulating the vessel which is entering the prostate once and for all. Once you coagulate that entering...
Energy and frequency, sir?
Yes?
Energy and frequency.
Energy and frequency, I am used to 40 frequency and 2 watts. So 80, 2 joules, so 80 watts. This I have a 100-watt machine, but for the prostate enucleation, I do with the 80 watts. No specific reason.
40 and 2.
Yeah, 40 and 2. So, and this is how you see, I have come very close to the sphincter zone at 2 and 3 o'clock position, and I incise the mucosa, and now trying to get into the proper plane for the lateral enucleation. And these are the tissue planes which are maintained at 12 o'clock. So the adenoma at the roof is being disconnected, and this is how the lateral enucleation has started. This is a small, attachment near the sphincter zone between 2 and 4 o'clock. So I have detached the adenoma early in my enucleation from the sphincter zone. So that is also one of the important factor to preserve the continence, that you do not give too much of a stress on the sphincter zone by not handling that area early enough in your enucleation. Still, a lot of tissue is attached to the capsule. So I am just proceeding from this for the lateral enucleation, and all the vessels which are entering the prostate are being coagulated right at the capsular level. And this is how I am completing. You can see this sphincter zone is, I am quite away from the sphincter zone, and small, all these tissue adhesions are being taken care of in the enucleation. And this is the lateral enucleation. This is between 3 and 4 o'clock position. So again, all this, once you complete this, you detach the prostatic end. So weight of the adenoma doesn't pull the sphincter zone into your surgical field, and the fibers of the external sphincter are not compromised to that extent. So this is how you preserve the continence. One of the important factors. Can you see this?
Yeah.
I'm just detaching. Now you can see the adenoma is detached and being pushed towards the bladder, and the capsule is more or less defined around the sphincter zone, and prostate adenoma is attached. So you will see various planes like this. You just have to come back to a normal plane again and remain close to the adenoma. At times, if the small nodule is very adherent to the capsule, I will leave that nodule on the capsule rather than compromising the capsule. I have not opened the capsule at all. And I have kept some of the prostatic tissue on the capsule so that on a later date you can vaporize that. But never compromise the capsule, and just try to, I'm cutting through the small nodule, but then again trying to enucleate entirely the left lobe. And this is how, this is only 9 minutes and 31 seconds since I started my enucleation. So this is all real-time video. I have not edited. I am just fast forwarding. Now I'll just finish this. Exactly. So this is 11 minutes 20 seconds, and left lobe is out. Left lobe is pushed into the bladder.
In terms of the speed, this is the fastest, no, sir?
I don't know, but
no. I'm comparing. The ultimate idea of talk is, like you have experience, when you do with everything, in terms of the speed of resection of grams per tissue,
Right.
this looks very fast.
I was coming to that. You said before I said anything that a good enucleationist resects at 1 gram per minute. So we were trained for a resection of a 60 gram in a 60 minutes. Though that was our limit in Manipal when I was doing urology, that you should not resect beyond 60 minutes because the PUR syndrome incidence is rising very high. So good resectionist resects 1 gram per minute, and I am enucleating on an average 2 gram per minute or enucleation. So you see the 60 gram prostate was enucleated in 30 minutes. And now I have started concentrating on the right side, and a little bit of median lobe was there. If you can see here in the video, I am trying to, at 6 o'clock position, I am trying to define the plane or floor of the capsule, prostatic fossa, and capsule is very well defined everywhere. The adenoma is being pushed upward and towards the bladder. So this is a small median lobe part of this, which is attached to the right side, which is being enucleated. So the right side enucleation has already progressed from the floor now. And you see here the right lobe is attached. And now I will come to that roof towards this thing again. Because we have detached from the sphincter zone, it is very easy to define the Lakshman Rekha on the right side. I am going to incise this mucosa like this. You see this? So this is how the lesosphincter is preserved. You go few millimeters inside that sphincter zone. I am well within that area of verum antenna, but not compromising in enucleating the adenoma. I am just incising the mucosa and then leaving adenoma to get lifted up between that, in that plane, but preserving the mucosa so that the lesosphincter fibers are preserved. And this is how the stress urinary incontinence reduces. This guy had not a single drop of incontinence on the day 1 of catheter removal. So see, you can see this small adenoma, whatever small nodules are there, which can be incorporated in your enucleation, you can. Otherwise, you just go through that adenoma, but don't compromise the capsule as far as possible. The depth of the holmium laser is 0.4 millimeter. Even if the capsule is perforated, it's like a needle perforation. So don't worry about that. But still, you avoid compromising the capsule so that you don't open up the sinus. Otherwise, the laser doesn't help in reducing the bleeding from the sinus. So we just have to have a bloodless plane all throughout and enucleation of the adenoma in a proper plane all around. And this is how the right lobe was enucleated. This is 16 minutes 46 second video and almost done right side. So you will see this. Now this is right side, 17 minutes and few seconds and almost done enucleation, and these major vessels which are supplying will be coagulated. So once and for all, the blood loss, average blood loss in my 60 gram prostate is about 30 ml of. I send the irrigant fluid for the hemoglobin analysis, which is a crude way of doing it, but at least something I can come to know what blood loss I am encountering. And this is last few attachments with the prostatic fossa, and I'll be finishing the enucleation of the right lobe also. So the entire enucleation is over in 19 minutes. And see this unedited video again. I'm just cleaning my fiber lens and then putting it again. And now this is Chandramohan. I wanted to show that you use the vaporizing capability, which is not very good, but small tags. You can do a good hemostasis. Spend some time with the fossa before you go for the morcellation. See this? I am just a few nodules I vaporized, wide bladder neck. I have ensured the entire prostate is enucleated nicely, and the field is very clear, good enough for morcellation. One of the very prime criteria of doing a easy and fast morcellation is that hemostasis has to be perfect, and the enucleate. See this small tags, I am just vaporizing it. It is always better to vaporize.
What is vaporization, sir? What is the setting for vaporization?
Same. 40 and 2. I don't see. While I was preparing for your lecture, I came to know that the effect properties of the laser doesn't change with the energy. Even if, our concept of reducing the settings and the power near the sphincter is of no use. the damage or tissue interaction is same with the 20 watt as well as the 80 watts. That is what the recent research has shown. And so you don't need to change frequently, and I am lazy enough to change my settings. At the end of this is how the fossa looks. And you see the nice prostate floating. And I have prepared, this is 24 minutes, 5 seconds. And I've already started morcellating. So the enucleation of 60 gram prostate took around 25 minutes.
Yes, sir.
So this is how the morcellation is done. And maybe I'll show one more video about the morcellation. This is the first part of the video. And second part also small video, 5 minutes extra. But this morcellation continues. I just want to show you the stents like this. You see, right side DJ stent, you see. And sometimes the morcellation, you see this tissue, which is very hard or firm nodule. The soft part of the prostate will get morcellated very fast. But these nodules they will bounce back with the irrigation, because you want a pressure irrigation. So they will run away from the blades. So you have to be very careful. So these are known as beach balls. Somebody has named them. So these are firm nodules, are headache for doing a morcellation. But at that time, you see what you do is that you make them irregular, or irrigation you slightly reduce and try to, there are some small tips and tricks to handle the nodules. But at the end of 5 to 7 minutes, morcellation is done. So when you weigh this morcellated tissue, it will show around 50 grams. So my speed of morcellation is almost 10 to 12 grams per minute. So this is how.
Some people say that very small cotton balls, if you make a TURP with...
Exactly. That is what I'm saying. There are various tricks. I do, I pass a DJ stent pusher and pass a laser fiber and make, laser cuts on the surface to make it surface irregular so that they can come into the grasp of the morcellator blades. Or worst come worst, you just resect the nodule, which is very firm. Sometimes very hard nodules we see, but they are benign again. So this is how the morcellation and the trick of morcellation. Now you can see right side DJ stent, you will see the left side DJ stent. This patient did very well. His creatinine came down to 2.9 and he started passing well and with a very good flow and no incontinence at all. And this was done in January and he has come recently last week only for the follow-up, and his creatinine is holding on to 3.2. So this is how the two-lobe technique of holmium laser enucleation you can see. And this is the end of the video. If you have any question, I will show you a bipolar enucleation now.
Yes, sir.
Now you have seen the holmium laser enucleation.
Just before going to bipolar enucleation,
you want
holmium laser, just pause, sir.
Okay.
Pause. 3 questions I will ask so that audience who is there are a lot of already 100 audience have joined. One question is, if the lumen is narrow, like in small pennies, anything you have tried with the smaller resectoscope?
I have been doing it for 5 years now. I was the first one to adopt. I presented in semi-live Goa my initial experience of about a year follow-up. I have been doing it with the 22 French outer sheath resectoscope laser sheath.
Which company you are using?
This is HoLEP. HoLEP was the first one to introduce. Now many companies have come up with the 22 French resectoscope. But the guy from the Brazil, he has popularized a smaller size. I have also done this and I'm going to publish my experience because now the follow-up is more than 3 years. I always wait for my 3 years follow-up because exact advantage of a smaller resectoscope is that is there a reduced incidence of a stricture urethra post HoLEP?
You feel that overall the size of the scope, if it is less, it is better? It is better overall?
My personal experience says that for a smaller 60 grams or 80 gram prostate, it is better than the normal 24, 26 French size resectoscope, because there is, the beak is smaller, so you get into the between the adenoma and the capsule, smaller space is needed. So the enucleation is better with a smaller size resectoscope. But there is a limitation. If there is a 150 gram prostate or a 100 gram prostate, urethra is longer, you have no advantage of using a smaller equipment. At the same time, you will find some difficulty reaching the bladder neck because of the length of the resectoscope, and you may find some
Oh shit. Hello. Sir, you lost the connection. Hello. So for the audience, what he wants to say is smaller ones is useful for the small glands. For large glands, bigger. I was thinking of other way around where enucleation for a long time. Sir, you have to reconnect. You have to reconnect fast. No problem. You reconnect, no problem. Yeah. Okay. In a hotspot also you can join with your laptop. Charger is the issue. Is it the charging issue or the Wi-Fi is the issue? No problem, no problem. You log in with phone, no problem. No problem. For the audience, he is logging again because of the current problem. So he will exchange his views because very few people do all the 3 types of surgeries. They can give clear this thing. I don't have experience with homium. I have done with bipolar enucleation as well as the homium. So he is joining, and we will ask him some of the questions before he join with the desktop. The idea of this.
Can you see me?
Yes, sir. Yes, sir. Yes, yes.
Now the issue is that my on generator my internet doesn't start. I have a power supply in my house, but the internet will not start. I'll have to use the 4G of my phone. Otherwise, we can continue discussion. You can finish the question answer session. If the electricity power comes back, I can log in again. Show you the bipolar.
Know how to connect with hotspot?
Yeah, I know. With the hotspot only, I wanted to connect through my. I think I'll do that.
Hotspot you connect with laptop, sir. So in coming to the hotspot you connect, no problem.
I'll try to join with the hotspot. Just give me some time to switch on my system. Meanwhile, you can ask me question. We can keep interacting.
Bipolar enucleation, when you rotate and push manually, sometimes you use bipolar energy to cut small fringes, but with the loop, you cannot exactly cut what you want to cut. You will cut other things also. For that, you have to manipulate forcibly. So during that time, I feel that a lot amount of stress will be there on the sphincter. Because loop is see, if it is loop, other people have designed Carl Starch, Peruman, his three-edged thing, different type of thing, so that it will go and fit in the curve, whereas loop will not fit in the curve. So most of it is done with mechanical. So what is your experience in that bipolar enucleation?
Unfortunately, I'll show you the video how I do it. I do it with the button electrode, and button electrode works for me like a end firing laser fiber.
Okay.
So you can get into the same steps. There is no different step. There is no different technique. It is just a different energy, and the sharp edge of the button will disconnect the fibrous connection between the adenoma and the capsule. So with the bipolar energy also, I do the same way as I do with the holmium YAG laser. The difference is only a plasma.
You prefer loop or button?
No, I don't use a loop. I use only button.
So what,
button
loop is thick, but you have to.
Loop. I found it very difficult with the loop and the beak always to enucleate because you are 100% dependent on a mechanical enucleation. Even the spatula also, you are always dependent on finding a plane between the adenoma and capsule by a mechanical enucleation. And most of the prostate, maybe 50 or 60% of the prostate, have prostatitis ailment in our practice, and always not possible to do a mechanical enucleation. So we have to have some energy which can cut through the prostatic tissue to avoid capsular injury and capsular violation. Just give me some time.
Yes, sir, take it, no problem.
Problem with the technology is that my now mouse is also wireless and it is not operating. I have never used in absence of my electricity.
Okay. And you can, Rajendra, you can give phone call, sir. And hotspot you can.
Oh.
Lots of people are asking. In just 2 hours. Service in Raja Society. Enjoy. Okay. Sir is trying to connect. We will wait for some time. Please be online so that we can continue the bipolar enucleation and the ThuFLEP fiber laser enucleation. Yes, sir. Hello.
Yes. I've started.
You got the connection? Very good.
Yes. Can you see the video?
Yes, but it is a little less quality.
I can see it properly here. Maybe my 4G also not that good like a Wi-Fi.
Yeah, yeah, internet issue. Will you be able to know your internet when it comes?
I don't know.
This is going well, no problem.
Right now, I think we can continue with this only. If
Continue,
you are
no
seeing
problem.
the video of a good quality.
Yeah, okay.
Again, this is a real-time video, unedited video. And I think 50-60 gram prostate. I just want to show you, this is the button. Can you see the button?
A slight pause will be there between you and me, 10 seconds. Yeah, I'm able to see the button now.
Okay. See, now can you see the video now?
It will take 5 seconds video transmission. Yeah, now I am able to see the video.
See, I use a coagulation current with the button to demarcate the distal limit of my enucleation. So I am doing a marking on the mucosa. Can you see this?
Yes, sir. Marking just started.
Okay. So this is how we do a marking on the adenoma. There is a groove always. Even if the adenoma is projecting beyond the verumontanum, it is not an issue. But some few millimeters of mucosa you preserve inside the sphincter zone. And this is how I mark my distal limit with the coagulation current. If you can see here, I am seeing it properly.
Yes, sir.
And this is how we demarcate from all around, 12 o'clock also. Is my button at 12 o'clock?
Yes, sir. 12 o'clock I am able to see now.
Yeah. So once I reach 12 o'clock, I'll use a cutting current now with the button. So there will be air bubble, and then I will mark my distal limit here. And this is how you mark the do anterior commissurotomy. So this is one landmark which is very important. So in enucleation, it is very important to have a landmark, and landmark which is correct, showing a capsule or some right plane. So even if you are lost during the enucleation, you come back to your right plane and then restart your enucleation again. You got my point?
Yes, sir. Understood.
So this is how 12 o'clock commissurotomy is done to mark my limit or incision here at 12 o'clock. Again, this is an en-bloc enucleation I have done with the bipolar, and I have done little bit of commissurotomy. I'll come back to the verumontanum and try to define the posterior capsule around the. Are you seeing this?
Yeah. I'm able to see now the veru and floor.
Right. So this is how with the cutting current you incise the mucosa, and small bursts of the bipolar energy. So you are cutting the mucosa. What you are asking me, this button makes it very not very difficult to get into the right plane. See, I am just small bursts of energy I am using, and the sharp edge of the button is also being used for that. Now, once you are in a right plane, you use a mechanical energy. So you use a combination of these both smartly to enucleate the adenoma at a correct place in a correct way. So whenever there is a mechanical force doing the job, don't use a current. But if it is not doing the job or I have to coagulate, I am using this current. Can you see this?
Yes, I can observe that.
Yeah. So this is to answer your query in the first place, that how do you get into this plane, and then this is the current, sharp edge of the button and the current. You see where the adhesions between the adenoma and the capsule, and be always in the right plane. So this is how we define the plane, and go slowly with the small burst of the energy. You don't continuously do unless you are sure where you are applying your energy. And mechanical energy with a less force, no force use at all, and the strength of the button is good enough. Can you appreciate this mechanical and then combination?
Yeah.
So nice. This is how the apical region on the left side, the capsule is defined. The capsule is supposed to be very close here. You incise the mucosa, get into below the adenoma, and immediately you'll see the capsule, and just follow that plane on either side. This is I am doing on the left side. I am simultaneously going to do the right side. The the correct way of identifying the capsule is that there will be crisscross vessels on the capsule. You don't go deeper than that layer. So I'm again incising. Can you see this edge of the button incising precisely?
Yes,
See,
yes.
this is how I say. This is how I say that this is doing a job like a laser machine, end firing fiber of the laser machine. You don't need a laser always to enucleate the adenoma. That is what the statement is, that any energy is good enough is used properly. And here the mechanical and electrical is good enough to enucleate all types of adenomas for me. There will be a difference. I'll talk about them later. That, see, otherwise, people would have used everything, but there is a difference of physical properties of every energy. You must appreciate that the plasma which is generated in the bipolar energy is having no control about the depth of the tissue penetration or coagulation necrosis. So we have to be very careful. You have to be very careful as when you are working at the capsule, near the capsule. So this is where small bursts of the energy is good enough, and getting into the right plane and then combining it with the mechanical energy. And this is how I am defining the capsule on either side of the verum antenna, defining the posterior capsule. First step of a en-bloc enucleation, that you separate and proceed as much as you can on either side of the 6 o'clock, that on the right side right up to the 9 o'clock, on the left side right up to the 3 o'clock. So you define the anterior capsule around the verum antenna all the way. So this is how I'm just going to fast forward and see this is how the posterior capsule is defined. Veru is here in the center, and you see this mucosa being seen in the anterior region. The prostate lobes are hanging, and this is again at 12 o'clock. I'm just orienting myself, and then I'm yet to see. I'm incising again here. Precisely, I'm incising the mucosa on the right side, and slowly I'm proceeding and separating the mucosa from the adenoma, so that the pull on the sphincter is minimum once you incise the mucosa, and then you proceed for the enucleation. See, now I am trying to do the enucleation. Once I have incised the mucosa, the fibers of the lysosphincter are spared of push and pull of the enucleation technique. So this is how you slowly get into the correct plane by using the electrical energy and the sharp edges of the button, and try to enucleate the adenoma in a very sensitive area near the sphincter zone, and you avoid the injury to the sphincter fiber. Again, in this particular patient was continent 100%. At times, they have stress urinary incontinence for 1 or 2 days or up to 2 weeks, but that is accepted when you do a good enucleation for the large prostate. But again, the pure stress urinary incontinence is less common. Again, small burst, I'm trying to incise the mucosa first. So this is very important and crucial step in the enucleation, that you separate the sphincter zone with the energy, with a very short burst and no push and pull. Once you incise this mucosa this way, the adenoma is getting separated from the sphincter fiber, and then you try to enucleate. Are you appreciating the video?
Yes, sir. Yes, sir.
So this is the key of preserving the continence during the enucleation. That you should be aware that you are working in the sphincter zone. You should be, slow enough and, careful enough not to injure the fiber beyond the Lakshman Rekha which you have marked. And you have incised the mucosa, you will never go beyond that limit. So the sphincter injury is less common. Some stress definitely occurs while you do the enucleation, but not to the extent that it will give you incontinence for a longer period. And once you are in the right plane, just mechanical push and then occasional use of electrical energy is good enough. But the tricky part, I'm not saying that everything is very easy. It takes time and experience to do all this thing. But again, small tissue is being vaporized at 12 o'clock because I have not done enough length of the anterior commissurotomy. So I am completing that length of anterior commissurotomy at the particular level, and then I will try to go around the adenoma on the other side to complete the lateral enucleation. I'll just fast forward this and see this. You can nicely demarcate here also. So there is a difference between laser and bipolar energy, but the technique is same. Can you appreciate the technique of separating the adenoma from the sphincter? It is same. So what I did with the holmium laser, I'm doing it the bipolar energy. The sphincter zone is on the outer side, inner side adenoma. I am trying to maintain in that plane and trying to enucleate in the sensitive area of a sphincter zone around a 3 o'clock or a 2 o'clock position, and try to enucleate the adenoma on the bladder side or medial side. And laterally there is a capsule. So you just maintain that plane and don't go very deep. And you have insights. Again, I'll go back to the 12 o'clock and see what is happening here. And there will be a bleeding. See, there will see like this. You just vaporize or coagulate with the button. Button is good enough to coagulate any vessel. But again, I told you, plasma of the bipolar goes deeper. Can you see this orange halo?
Yes, sir.
You have no control of depth of penetration of this halo. So the bleeding is more in bipolar enucleation compared to laser. Laser is supposed to be more precise for the coagulation, and equally good. Bipolar is also good for cutting, but precision for hemostasis, I think laser scores better. So that is why the blood loss in my bipolar enucleation is slightly higher than compared to the holmium laser. So if this prostate, if I had done with the holmium laser, the blood loss would have been 30 ml, but with the bipolar, it goes up to 100 ml. So, but again, it has no clinical significance. Even if the patient bleeds to 100 ml, he doesn't need a transfusion. So there is no clinical difference or significant in blood loss we incur by changing the energy for the enucleation. And you have to be careful about each and every small vessel. The key of reducing the blood loss during enucleation is that not to violate the capsule, because it is very easy to perforate with the bipolar. And in the initial learning curve of this thing, I have violated the capsule many times, and sinus bleed definitely.
Sir, we will little fast forward. It's 1 hour now.
I know. So I'm just finishing the video presentation part. I'll show you the later, the end of this. You got the point which I wanted to make for the bipolar enucleation.
Understand. It is clear. Now it is coming clear. There is no problem.
Yeah. So this is how the last few steps of bipolar enucleation, and I'll go to the next video, which will show you. Yeah. And finishing touch of the bipolar enucleation. Again, bipolar also is a good real-time video. This is how I finished my bipolarization and do a vaporize, I think, morcellation. Before I do morcellation, I coagulate all small vessels and take care of the hemostasis first. And this is the left ureteric orifice. There will be some oozing at the bladder neck, so you just coagulate those with the bipolar and see that the urine is absolutely clear before you take the morcellation. And I'll show you the adenoma, how it looks at the prostate, and then I'll finish this video. And you can vaporize small nodules which you have left behind at the fossa. Sorry. I just want to show you, this is how the entire en bloc enucleation, all three lobes are seen nicely. You can see this?
Yes, sir.
So this is en bloc enucleation with the bipolar energy. And you can see this entire thing will be morcellated after this enucleation. HoLEP for the small lamp, I'll skip this. See, the first time which I started doing bipolar enucleation was in 2016. So in 2017, I presented the comparison. Can you see this slide?
Yes, sir.
Hello?
Yes.
So this is the poster I presented. AUA Boston, I presented this. And 2019, I published my technique of bipolar enucleation in Video Urology Journal. And 2022, last year, I published my 3 years randomized prospective trial. And this is the result, that operative time, enucleation time, and that was better than the bipolar. And they think the drop in hemoglobin was also not that significant. So efficiency of HoLEP was better, but at the end, the IPSS and all these parameters were equally efficient. Outcome was same in bipolar and HoLEP. That is what we concluded. And this is one of the 2020 review article which compared the laser with the bipolar. I think this was from the Chinese group published in World Journal of Urology. They also say it's the same thing, that early efficacy and safety profiles are comparable between laser and non-laser enucleation, but the laser has got small drop in hemoglobin, shorter catheterization. And another review which has come.
Ajay sir. Hello.
Yes.
It's 1 hour 10 minutes.
How much minute we have?
1 hour 10 minutes. We have 1 hour 10 minutes. We have done already.
Okay.
So maybe another 10 minutes we can take, because 1 hour usually we keep as the.
I know. There was a technical hitch, and I'm sorry about it.
So, do you have a ThuFLEP video? Anything?
No, ThuFLEP video I don't have right now.
Okay.
I want to share something about the ThuFLEP. Recently we have realized that the thulium YAG also has a property-wise, it is better compared to holmium YAG laser. And this is one review article which shows that the HoLEP is. So you will find in the literature everything comparable, or in one review or meta-analysis, you will see HoLEP is better in a more than 80-gram prostate. And this was another, meta-analysis which compared head-to-head holmium with the thulium. And they said that thulium is safer and less blood loss. So the outcome between the thulium fiber and thulium laser, or the properties, are more or less same. And this is how the laser beam tissue interaction happens. There is a vaporization, coagulation zone, which is reversible, and the coagulation zone on the outer aspect is reversible and inner aspect is irreversible. This is a very important part, because people have realized that the shockwave dissection of the holmium laser is very high. So it is a blunt dissection because of the pulsed energy, and thulium fiber as well as the thulium YAG laser has got excellent hemostatic and cutting properties. So yes, thulium fiber laser also has better cutting property like a thulium YAG laser. So enucleation with that energy should not be having any problem. I have done only few cases with the thulium fiber and around 70-80 cases with the thulium YAG laser. This is all theory, because the depth of penetration of thulium fiber laser is favorable, what they say. And theoretically, they say that the peak power of holmium is very high, which is not a good sign for a good enucleation or a tissue interaction property. And the property of tissue interaction of thulium as well as thulium fiber laser is most favorable. So theoretically speaking, thulium fiber laser will have an advantage over a holmium for the soft tissue application. Also, good news for you all guys, that thulium fiber laser is also supposed to be equally good or better than the holmium laser as far as tissue interaction is concerned. But another recent publication by our own Indian guy, Hemant Shah from Mumbai, who was shifted to USA, he compared on the prostatic tissue coagulative necrosis depth of holmium laser, then Moses holmium laser, and TFL, which he found there is no difference between the depth of coagulation necrosis. So these are
Sorry, your voice is breaking.
Can you hear me now?
Yeah, better.
Hello?
Yes, sir, better.
So this is my last slide. This is again a big group. All of you, maybe I think a few Indians have also participated in real world setting of a AEP, that is now real enucleation, I think anatomical enucleation of prostate, refined endoscopic enucleation. And their conclusion was also that EEP works very well and we should adopt it. And I would conclude my talk by saying that the technique of prostate enucleation levels out the disadvantages of the instrument or the energy used. So you always should think about endoscopic enucleation, and TFL has an advantage of having a universal energy with improved logistics, because the machine is smaller, it works very well, and the property is also favorable, physical property. Versatility is also good, and it is cost efficient, which is also equally important. Thank you.
Thank you, sir. So I will ask few questions quickly. Can you stop sharing the screen?
Yeah. Yes.
Number one, if you
Hmm.
have less than 60 grams prostate, is not very rich, what will you choose for him? Number one question.
Bipolar enucleation. Bipolar enucleation.
TURP or enucleation?
Both. See, for a 60-gram prostate, I am comparing my resection as well as enucleation study, and the outcome and complications and efficiency is same for both, up to 60-gram prostate. So I think 60-gram, if patient insists for enucleation, I'll do a bipolar enucleation. Patient is not very affording and I have to do a compromise, I'll do a good TURP.
Number two, in enucleation of prostate by holmium in large glands, do you ever felt patient yawning, disorientation, moving the legs, all maybe because of whatever dyselectrolemia or fluid overload? Does it happen if you cross more than 1.5 hours?
I think that problem is never there with the laser enucleation because using a normal saline and not a sterile water. So normal saline irrigation for a holmium laser enucleation, I have never encountered TUR syndrome like symptoms or signs of fluid overload. So that was not an issue with holmium laser enucleation.
When will you prefer under GA? Is there any indication for GA or always under spinal?
I do always under spinal, provided patient is not on anticoagulant, strong clopidogrel and all that. My anesthetists, they don't prefer spinal.
Ask in clopidogrel, if cardiologists say that cannot be stopped, what is your protocol?
I do holmium laser enucleation with the clopidogrel on. So I tell my patient that some irrigation will continue. Usually it stops before 24 hours. For you, 1 or 2 days more, and some hematuria will continue for 15-20 days with the clopidogrel on. And yes, clot retention also happens, but not very life-threatening clot retention like it used to happen in TURP.
On an average, for 100 grams prostate, how many bottles of normal saline you will use?
I have never counted, but I think 8 to 10 saline 3-liter bottles are used for my...
Including morcellation?
Yeah, including morcellation.
Okay. In bipolar...
Time is very important. Time. See, you noted all these videos are actual videos without any editing. And I told you 2 grams per minute enucleation time. For 80-gram prostate, I don't take more than 40 minutes. So the irrigation is also comparatively less. For a 60-gram prostate, I don't cross beyond 30 because this is all because of the experience of 20 years. Even initial, so that is what, that overall, even if for the beginner, those who overcome the learning curve, enucleation will always be faster than the resection for cure.
Okay. Have you ever encountered postoperative torrential bleeding following enucleation going back into the theater?
Yes, all these high-risk factors, clopidogrel. One of my ITP patient bled like anything. I had to take him twice or thrice despite holmium laser enucleation. So holmium laser enucleation is no guarantee that he's not going to bleed. But the incidence is very less. I think less than 10% compared to the TURP incidence. I'm not saying 10% of my patients. The incidence of my first 20 years of TURP and incidence of my last 20 years of clot evacuation, it has come down by 10 times.
Do you do OTs before doing all these procedures?
Ever since I started using 22 French, I am not doing anything, but I do dilatation. I don't do OTs routinely. I just dilate the entire urethra before putting in my resectoscope.
Okay. Have you ever perforated capsule to the extent of perivesical collection leading to drainage?
Never, ever. I have in 20 years of my morcellation of maybe now 4,000 enucleations, I have not perforated a bladder, even the morcellation also. Forget about the enucleation. Because you don't compromise on the principles of morcellation. Yes, few mucosa will get caught once in a while, but I have never full-fledged perforation encountered due to morcellation. Enucleation, definitely, capsular violation will be there. The maximum capsular violation occurs at 6 o'clock, where you have to go up, enucleation, and that plane you have to maintain. And the capsule is thinnest around the bladder neck. So that is where the capsule is violated.
What is the largest gland you have done with these procedures?
360 gram by the holmium, 250 gram by the bipolar.
In 360 grams, when you are doing, is it the volume hindering your movements? Is there any problem? What is the important tips and tricks, 2-3 tricks in a very large gland? Is it easy to enucleate or difficult or same?
I think by holmium laser, the volume doesn't, it helps me. I always insist that for holmium laser enucleation good, I need a larger gland. But for 300 gram prostate, I did it in a 3-lobe technique, so each lobe individually. And by that time, it was already 1.5 hour, 45 minutes. So I avoid doing a morcellation, and that is the easiest way of doing it. You leave these 2 or 3 big chunks of lobes of the prostate in the bladder, put a catheter, and they will not hamper with the catheter irrigation. If you come back for morcellation after 48 hours, because of the no vascularity left, they becomes very soft, and the morcellation takes 10 or 15 minutes maximum to morcellate those big chunks.
What is the morcellator you use routinely?
Piranha. I have been used to only one morcellator. I have tried several morcellators, Stores and Biored and everything. All of them are good, but I am more used to Wolf morcellator.
Okay. For youngsters, last question. For youngsters who wanted to learn enucleation, 3 things there. One is watching videos, go to the mentor and work for 1 month, or try himself for 10-15 cases. What do you think is, who is good at TURP, of course? What is your take-home message for the youngsters to start with enucleation?
I strongly believe that those who are good at TURP will be good at holmium enucleation also, or any type of enucleation, because somebody who is aware of anatomical plane, somebody who is aware of capsule, where the capsule is, somebody is aware of how the instrument works in a different way, but he will pick up the enucleation faster. I always prefer that mentorship is the best. You see a lot of videos, you see an expert doing a video, you assist an expert, and then you try to do few cases and then invite some expert your place and then try to learn from him. So all this in combination will take at least 50 to 100 cases to be really very confident in every situation. And there is nothing to lose. See, you have to have that willpower to learn enucleation. You do enucleation. If you are stuck, you change your the loop and resect the prostatic adenoma and don't do any harm to the patient. So overcoming the learning curve should not be a stress to any urologist or a good resectionist. So only thing is the mindset that you should be prepared to learn the enucleation. That's it.
Right, sir. Thank you very much for that extensive presentation. Really appreciate that.
And thank you. And I'm again, sorry about the technical issue. Even right now, light is not there. This happens, and hotspot has saved us.
Yeah. Good.
It is always wonderful to interact with you, Chandramohan. You have been so dynamic. I admire you for your energy, for everything what you do. So thank you.